So if you press play, that's great. So thank you. So today's talk is going to be on hypofractionated radiotherapy, how to ensure the best outcome for breast cancer. Next slide, please. So I have no conflicts to declare in regard. So today's talk is really going to touch on 4 areas: where we began, the rationale and evidence for hypofractionation, how that's been applied in the context of treatment, and then really looking at 21st century cancer care. And then there'll be time for questions. Next slide, please. So where it all began, if we move on to the next slide. So it really began with the radical mastectomy. So surgeon William Stuart Halstead began this in the late 19th century. And as we know, mastectomies at that time were radical procedures, removing much of the tissue, including the breast, lymph nodes, and underlying muscle. We go to the next slide. Like so much in life, though, we've seen an evolution of surgery where we now do breast conserving surgery, where the tumor lump is removed from the breast. And essentially, as you can see, we describe this as a lumpectomy or partial mastectomy or segmental mastectomy. So our surgical techniques have evolved. Next slide, please. And so to complement surgical evolution, the question was raised, well, why do we do radiotherapy after breast conserving surgery? Essentially, radiation post breast conserving surgery has demonstrated reduction in the rates of both local recurrence and breast cancer death. Next slide, please. So you can see here from the Lancet paper, first recurrences with breast cancer surgery and radiotherapy reduced, and also breast cancer death. So it's an important modality of treatment to offer patients who've had breast conserving surgery. Next slide, please. So what's the science and rationale behind hypofractionation? Next slide. So really the principles of radiotherapy that we practice is to deliver a high dose of radiation to the tumor, a low dose of radiation to the normal tissue, and the greater the difference between those two, the greater the therapeutic ratio. Next slide. So here we see the therapeutic ratio. So you see the blue line is tumor control, the red line is normal tissue damage, and you can see as we increase the dose of radiation, you improve tumor control, but you cause more normal tissue damage. So what you want to try and achieve is really that black dotted line there where you see tumor control with reduced normal tissue damage. Next slide, please. So what is fractionation in radiotherapy? So the dose of radiation is given in fractions. There's normally a number of equal parts over time. It's usually once a day. And the typical historic dose of radiotherapy to the breast was 50 gray, the unit of radiation, in 25 fractions over 5 weeks. Next slide, please. Why do we fractionate? Well, fraction size is related to the risk of long-term effects on slowly dividing normal tissues. So if you double the fraction size, you quadruple the risk of late effects in tissues. So changing the fraction size has little effect on rapidly dividing tissue, so certain cancers. Therefore, small fraction size can enhance that therapeutic ratio. Next slide, please. So we often refer to something called the alpha-beta ratio of tumor, and we attribute that to different tumors, different values. So for certain tumors, the alpha-beta ratio is high. For instance, head and neck squamous cancer or small cell lung cancer. And so essentially, in other tumors, it's lower. So prostate cancer and breast cancer. So where you have a lower alpha-beta ratio, like normal tissue, there seems to be a benefit from hypofractionating, giving a larger dose per fraction. Next slide, please. So hypofractionation essentially then is dividing the treatment into larger doses per day, which again is normally given once a day or less often. It's typically given over a shorter period of time, which essentially means fewer days or weeks than standard radiation therapy. Next slide. So historically in breast cancer, after breast conserving surgery or mastectomy, the dose we've referred to is 50 gray in 25 fractions, which essentially equates to 5 weeks of therapy, followed possibly by a boost for a further 2 to 3 weeks. So if we plan to hypofractionate our patients, we want to ensure that the benefit is at least equally as effective in terms of oncologic outcomes, that the cosmesis is as good, it's convenient, of course, to the patient, and potentially it can reduce the burden on your radiotherapy treatment machines. Next slide. So let's look at the evidence behind hypofractionation for breast cancer. Next slide. So if we look at the early evidence, it was felt that there was a fear of increased late effects and worse cosmesis if you increased your fraction sizes above 2 gray, which was the standard at the time. Initial early hypofractionation studies in the 1970s really failed to address adequate dose adjustments with respect to high doses per fraction, and we saw excessive late toxicity. So schedules with lower total dose being delivered in fewer fractions were popular then in the UK and Canada, and as we'll see from the studies, 40.05 gray in 15 fractions over 3 weeks reduced the number of visits for patients and seemed to result in equality in terms of oncologic outcomes and suitable cosmesis. If we go on to the next slide. As with many evidence points in oncology, often the first evidence we begin to accrue is case series and cohort studies evaluating outcomes. And you can see here from these early case studies and cohorts that there seem to be equivalents in terms of low local recurrence and reasonable cosmetic outcomes at 5 years. Next slide. And then there was the Cochrane collaboration conducted a review of fraction size in radiation treatment for breast conservation in early breast cancer. And they showed that there was local recurrence-free survival, breast appearance, survival at 5 years, late skin toxicity, and late radiation toxicity seemed to be as good, if not better in some aspects, than conventionally fractionated radiotherapy. Next slide. But if we look at randomized trial evidence, the gold standard of what we attempt to practice in our respective practices, you can see here a significant list of randomized studies that have been conducted to validate the rationale for using hypofractionation in breast cancer, and more recently, the use of extreme hypofractionation like the UK Fast Forward trial. Next slide. If we touch briefly on some of these studies, so the Ontario group looked at 50 gray in 25 fractions versus 42.5 in 16 fractions. Next slide. You can see from the updated results, so these are the initial results for cosmetic outcome and local control, and you can see that there was similarity in both arms. Next slide. But in terms of long-term results published in the New England Journal of Medicine in 2010, next slide, that again, there was good equivalence in both arms with a median follow-up of 10 years. Next slide. And you can see here in terms of survival, you really would struggle to fit a laser pointer between the two arms of the studies in terms of difference. Next slide. If we look at the UK START A and B studies recruiting over 4,000 women, again comparing hypofractionated regimens, we move on to the next slide. You can see that the equivalence between the 50 gray versus the 41 and the 39 were equivalent in terms of local regional relapse. Next slide. And in terms of cosmesis, you can see that the 50 gray seemed to be as good as 41.6 gray. Next slide. Loco-regional relapse and distance relapse between 50 versus 40 again seem to be very similar. Next slide. And in regards to ischemic heart disease, again, you can see that the fractionation schedules between the two didn't really seem to see a significant detriment in the hypofractionated regimen. Next slide. So if we look at the summary from these studies, essentially you can see that the randomized studies have validated the idea of using fractionated regimens of sort of 3 weeks of therapy versus the historic standard of care of 5 weeks. Next slide. And more recently, we've seen the publication of the fast-forward studies. This is extreme hypofractionation, 1 week versus 3 weeks. And they've now published the 5-year efficacy in late normal tissue results. Next slide. And here you can see that 40 versus 26 in 5 seems very similar. And in fact, in the UK, at the onset of the COVID pandemic, many centres, including myself, adopted 26 gray in 5 fractions as our new standard of care for select patients. Next slide. So in terms of the summary of those studies, the cosmesis from hypofractionated radiotherapy seems to be good to excellent. It offers similar loco-regional control rates. It's more convenient for patients with reduced visits to hospital. It's potentially more cost effective. And given the multiple randomized controlled trials, the data seems to be robust. Next slide. So let's look at the appliance of science to radiotherapy. Next slide. So like Halstead in 1886, radiotherapy has moved on as well. Here's an early image of brachytherapy for breast cancer, covering the breast and the regional nodes. Next slide. Here's 1905 from the Royal London Hospital, not far from where I'm based, showing state-of-the-art radiotherapy in early 20th century. Next slide. And with the adoption of the microchip and computer technology, radiation treatments have moved on. Next slide. So we now are able to see inside the patient, and we can define the anatomical structures within the patient clearly using CT and MR imaging. Next slide. And so we can begin to appreciate the potential consequences of the treatment we're delivering. Here you can see the distal anterior descending coronary vessel within the treatment field. Next slide. And what's become clear here again from the New England Journal of Medicine, that if you irradiate patients' hearts indiscriminately, you can cause significant morbidity and cardiac dysfunction later in life, which of course has a knock-on effect in terms of morbidity and mortality. Next slide. So you can see there, left-sided breast versus right-sided breast radiotherapy, the significant difference in dose received to the heart. Next slide. So with the advent of technology, we're now sculpting our radiotherapy treatments around the organs at risk, whilst ensuring we include the at-risk areas. Next slide. So that we can avoid dose to critical structures and avoid unwanted toxicity. Next slide. Here you can see 3D conformal radiotherapy versus intensity modulated radiotherapy. And I hope you can appreciate that you can reduce the unwanted dose to the heart there, which reduces the potential risks of cardiac morbidity. Next slide. Sorry. Or you can do more mechanical routes of heart avoidance. Here, for instance, deep inspiration, breath hold. Next slide. Which essentially minimizes the dose of radiation to the heart. So your radiotherapy department obviously needs to have the staff and the skill training to be able to conduct this in your patients. But if you can, it potentially has meaningful benefits for your patients. Next slide. Or you can avoid external beam radiotherapy altogether, potentially, and use intraoperative radiotherapy. Next slide. Delivering your dose within the tumor cavity using low energy photons, which again helps to minimize the dose to your organs at risk. But again, time will tell through further studies whether this is a sound and practical approach to the patient's treatment. Next slide. So let's quickly look at the fundamentals of 21st. Next slide. So essentially the vision, so every cancer patient I treat or is treated in our center hopefully will have, and if you just click through these.
Click. Samir, click the.
Access to state-of-the-art radiotherapy. Their treatment individualized the needs of their cancer, both the molecular and histological characteristics, taking account of the patient's personal circumstances, for instance, their comorbidities. And again, access to the highest quality planning. So it's all very well having the latest technology, but it's important that when you plan the patient's treatment, you obey the ICR rules and you treat the tumor and avoid treating normal tissue. Next slide. So again, it's important to remember when we're treating patients with cancer that because of these individual needs, that we discuss them within a multidisciplinary team setting so that each modality of treatment can share their thoughts and feelings to optimize the patient's care. Next slide. So that we can integrate all the potential treatment modalities we have to provide an optimal outcome for our patients. And here you can see the team I work with in Barts, with all the different specialties from physics to radiographers to dosimetrists to really optimize the patient's treatment. Next slide. Using the latest state-of-the-art machinery. So here's one of our Linacs. Next slide. And here you can see in terms of the pathway, it really is important for quality assurance that patients are taken through a well structured pathway to ensure optimal delivery of care at every point through it. Next slide. So that we can put the patient really at the focus of what we do. Next slide. And then finally, I thought just a few slides on tomorrow's world today. Next slide. So with the advent of possibility that proton therapy will offer patients equivalent in terms of oncologic outcomes, but reduced morbidity and the consequences of cardiac radiation. Next slide. There's an example planning study showing photon therapy versus proton therapy. You can see the furthest image on the right there. Essentially, that's the radiation dose you avoid using protons. Next slide. And again, you can see the heart-sparing effects of proton therapy there. Next slide. So again, for the surgeons here today, it really is considered gold standard in cancer care because surgeons can see the reality, adjust their treatment to the shape of what's going on. They can see in front of them and strike around the motion of normal vessels, etc., to attack the tumor. Next slide. But with the advent of new technologies, for instance, the integration of MR imaging, I think we edge ever closer to the goal of surgery. Next slide. So this is an example of an MR Linac. So this is the one created by Meridian. Next slide. And what it really allows us to do is to be able to see within the patient's body with much greater ease, soft tissues, for instance, muscle and bone. And that allows us, again, really to harness imaging into our radiotherapy delivery so that we know what we're treating. Next slide. To the point where we can even see during the patient's treatment, so this is MR Linac delivered radiotherapy to a breast cavity twice a day for just a week, and the video will play, but essentially it allows you to see as the patient's lying there whether or not the cavity moves, so that you can switch the machine on and off to avoid unnecessarily treating normal tissue whilst maintaining the dose of radiotherapy to the patient's lumpectomy site. Next slide. So there you go, that's in real time. And the early evidence that's beginning to be collated from this technology is that it does seem to offer things like partial breast radiotherapy with very high doses, with excellent outcomes, potentially in terms of cosmesis. But of course, only time will tell as we gather more, hopefully, randomized evidence using these new technologies. Next slide. So to summarize, really to achieve the best outcome for your patient having hypofractionated radiotherapy, I strongly recommend that discuss an appropriate breast setting, that you apply the best evidence to their care when it comes to the radiotherapy you're delivering, that you use the most appropriate radiotherapy technique, bearing in mind their nodal status, their tumor size, the surgery that they've had, that you use the best radiotherapy technology you actually have access to, that you ensure when you come to sign off their radiotherapy plan that it obeys the ICRU laws and that it can be the best that it can be. And of course, let's not forget that you monitor them during and after their treatment so that you can treat them for side effects and of course the potential late complications of their radiotherapy, for instance, cardiac morbidity and mortality. And I think that's the end.